Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Welcome to the AAOMPT podcast. My name is Leanna Blanchard. I'm excited to present today's guests, Morgan Zaranec and Katlin Millin Daignault. The three of us presented a session at the 2023 AAOMPT conference titled Cancer, Not Always a Contraindication to Manual Therapy. Morgan Zaranec received her Doctor of Physical Therapy degree from the University of Illinois at Chicago. Morgan was introduced to oncology and lymphedema rehabilitation during her clinical rotations and went on to work for UIC as a physical therapist with a focus in orthopedics, breast cancer rehabilitation, and lymphedema. Her passion for teaching led to working closely with the DPT program at UIC as a lecturer and lab assistant. She then sought out further training via the oncology residency at the James Cancer Hospital and Solove Research Institute at The Ohio State University Comprehensive Cancer Center. During her residency, Morgan treated patients across the continuum of cancer care, from survivorship to palliative and hospice care, in both the inpatient and outpatient settings. Her clinical interests include orthopedic, thoracic, and geriatric oncology, along with multidisciplinary care for patients with head and neck cancer. Katlin Millin Daignault received her Doctor of Physical Therapy degree from Marquette University in 2012. Katlin is a board-certified clinical specialist in orthopedic physical therapy and was recognized as a fellow of the American Academy of Orthopedic Manual Physical Therapists in 2018 after completing her manual therapy fellowship at the University of Illinois, Chicago. Her passion for teaching led to an adjunct clinical instructor position at Malcolm X College, where she taught anatomy and kinesiology. Her current academic appointments include a contracted guest lecture position in the DPT program at Rosalind Franklin University, as well as mentoring and lecturing in the Northwestern University Fellowship in Manual Physical Therapy program. She's practicing at Endeavor Health Hospital Systems in Evanston, Illinois, and her clinical and scholarly interests include orthopedics and sports medicine. We plan to approach today's podcast just a little bit differently. Rather than me interviewing these two about our presentation, we plan to have a little bit more of a discussion about manual therapy and how it may or may not be used in the oncology population. So first off, I would like to thank you both for joining me.
Thank you for having us.
Yes, excited to be here.
So just a question to get us started. Why did you want to present on this topic? Why are you passionate about it?
I have to say that as many of us, I feel like as physical therapists, we have that one patient who maybe presented a situation that totally was eye-opening to a topic that we maybe didn't know much about and had to do a deep dive. And I can say that my true interest in wanting to align with you two with presenting this and writing this up was a patient who truly changed my clinical life, especially as more in regards to how physical therapy can be utilized and primarily how it's underutilized in this population.
Yeah, and I think those are good points that Katlin touches on. So, I mean, as you mentioned in my bio, Leanna, I have a pretty broad background with orthopedics and then breast cancer rehab. And my main motivation for going into an oncology residency was simply that I was getting more and more cancer-related PT referrals and really felt that I just didn't have the training to see these patients and that I felt really underprepared and that school really doesn't cover it as much as other topics. And so it's really important for me to kind of mesh my orthopedic background along with my oncology background. And so this presentation and then this patient that Katlin's referring to was a good case study for us to build off of.
And I think for me, I kind of echo everything you both have already said. And I think the focus for me comes back to the fact that, like Morgan, I was seeing a lot of orthopedic patients that maybe had a prior cancer diagnosis, but then I was also seeing breast cancer patients and survivors of breast cancer, and there was just not a lot of guidance on could I treat patients safely with manual therapy? What should I do? What should I not do? But there were clearly impairments that I felt like manual therapy would be beneficial for these patients. So I just started to think about pushing the boundary a little bit and trying to understand what might be useful and safe versus not safe or not effective.
I think the conversation around research is so important to have because especially with this population, as above all, do no harm is the mantra for all of our patients, let's be honest, right? There's really, the paucity in the research is just so deafening of what's appropriate, what's not. I mean, of course we have our red flags, but the gray is overwhelming in terms of making decisions. And that's what I feel like is so important to kind of define what that gray means, meaning what specific manual therapy might be absolutely safe, but no one has written it up yet, or maybe specific dosage of exercise, which exercise I feel like is probably, I don't know if you would agree or disagree, both of you, but like exercise is probably the most well supported in this population in terms of intervention. Do you think we can safely say that?
Yes, absolutely. And especially in the last 5 to 10 years, there's been a lot more research, high quality research that has come out that does support exercise for patients with cancer and survivors of cancer, indicating not just that it is safe to do so, but that there are actual real health benefits associated with exercise. Whereas manual therapy, when we worked on this presentation, we found some good research, but certainly not a lot that directly points to orthopedic manual therapy. We see a lot of research in terms of, manual lymphatic drainage and stuff like that, but we don't see a lot in terms of joint mobilization or more soft tissue mobilization.
Right. And it's almost just excluded, even with treating like peripheral joints, like, maybe not at the site of potentially metastasis or, even like a post-operative, something that's been like, orthopedically fixated. But I mean, we have such an overwhelming amount of fantastic research in the manual therapy world on everything, excluding, oncologic cases. So I think it really made me think, well, how do these patients fit under an already existing algorithm to utilize manual therapy when there's a lot of great techniques that we can very safely use, but we really shouldn't spend much more time excluding this population when it can be and is very safe in many situations, as long as you have great access to their charts and keep open lines of communication with their oncologic care team.
Yeah, I mean, I think about all the studies that I've looked over and read in just the general orthopedic realm, and how often do you see that cancer is an exclusion criteria, right?
Yeah, all of it. You're taught to just, well, cancer, then I can't, probably shouldn't touch the patient. And that's probably how I felt as a new grad. I'd be interested to hear how Morgan feels about and you, Leanna, as well, like pre and post, training and residency training in this exact field. Did you guys feel similar, like, oh, this is a hands-off patient, functional strengthening at best? And then how did that change after what you've learned?
Yeah, I mean, I think a really important point to bring up is that oncology specialization is still so new, and the population of oncology specialists is so small. So as of 2023, there's 187, I believe, board certified specialists in the United States. And there's multiple states that have absolutely no specialists or, very minimal specialists. And so the need of the oncology population far outweighs the supply of therapists that are really comprehensively trained to treat them. And so I think orthopedic therapists are in a really great position to be able to service this population. And especially because so many orthopedic therapists have gone through residencies and fellowships and have really great clinical reasoning skills and really are very talented therapists, I think that it can really help fill in the gap. For Leanna and I at UIC, when we were seeing a lot of patients after breast cancer surgery, it's interesting because you do learn so much in school about the contraindications of treating a patient with cancer. But, Leanna can touch on it as well, but we used hands-on techniques all the time. I would say, especially for patients right after surgery, we were primarily using manual techniques really to help modulate pain, help improve mobility and range of motion when they were in so much discomfort and unable to do these things themselves. And so I think a lot of those ideas that kind of are put in your head in school really went out the window when you have a patient sitting in front of you who's just expressing so much discomfort and feeling so hopeless in some ways that, I have this really daunting diagnosis in front of me and I've gone through a significant surgery. I need radiation and chemo, and I can't even lift my arms to wash my hair or put on deodorant, and so those things, it really humanizes the person in front of you and makes you kind of take a step back and think, well, how would I want to be treated if I was in this patient situation or if this was my family member, and I think that kind of can help also change your perspective on it and help provide a little bit more well-rounded approach.
Mm-hmm.
And I think one of the things that maybe we can touch on a little bit in this discussion is, when would you not do manual therapy on someone, or what techniques might you not do on someone? Because there are a few things that we want to be more cautious about. But generally speaking, I think like Katlin said, it's utilizing clinical reasoning and treating the human that's in front of you and not the diagnosis, right? It's making sure that we look at someone and what they need to do functionally to enjoy their lives and have quality of life, and weigh the pros and cons of, how do we most effectively treat this person, what's safe to treat them, and why would we do manual therapy or why would we not do manual therapy. I mean, I don't know about you guys, but I think a lot of times when we hear cancer is a contraindication for, you name it, a modality or a treatment, whatever it is, I think historical fear is that by doing those things, we would potentially spread someone's cancer. And I think there's a lot of interesting evidence out there now to show that that's not the case. I'm certainly not going to use certain modalities over the active site of cancer, but if I use my clinical reasoning to apply them outside of a certain area or to utilize manual therapy outside of a certain area, that's probably okay. We have to weigh the cost and benefit for each patient individually.
Right. And I think another probably big fear is, if we kind of like myth bust I guess not myth bust, because sometimes it really, I guess, could happen if the wrong technique is utilized, but, spreading, quote unquote, spreading the cancer or like causing a pathologic fracture in a patient with an existing bone met, right? I think we see these things and the rest of our clinical decision making almost becomes paralyzed because, of course, a pathologic fracture is the last thing we'd want to occur under care. But I think we need to remember in that moment, we need to consider there's other sources of nociception that might be also active. There might be a local tendon or soft tissue pathology. There could be an underlying joint pathology at a joint more proximal if it's like a spinal met and there's some hip OA at the same time. So it's a huge disservice to a patient to assume that the only source of their subjective complaint of pain is maybe only related to their cancer diagnosis. I mean, largely it definitely could be. So I think that's important with your subjective reasoning and have access to imaging. But we have to assume that there's other things that we should be asking questions about, other hypotheses that we could absolutely manage with PT.
So I think this brings me to the question of, how do each of you approach manual therapy in patients that either currently have cancer or have a past history of cancer? And Katlin, you kind of started to touch on this. What are some of those things that you need to stop and consider and reason through, and how do you do that? Where do you start?
Yeah, I mean, I think those are all great questions, and I work in a comprehensive cancer center, so every single one of my patients has a cancer diagnosis, and most of my patients are in active treatment, but I do have some that are in a remission status or kind of just on maintenance therapies. But the biggest thing that I notice is that my examinations really don't look a lot different in the comprehensive cancer center compared to when I was in a primarily orthopedic clinic. I'm using a lot of the same clinical reasoning and a lot of the same techniques, just taking some extra considerations like you mentioned. And so some of those might be for women who have had breast cancer or any type of gynecologic cancers, understanding that if they've had aromatase inhibitor therapy or undergone ovarian suppression, that they're going to have higher risk of osteoporosis, and therefore higher risk of fractures. And the same goes for men who have had prostate cancer, and have undergone androgen deprivation therapies, that they will also have decreased bone density and are also at a really increased risk of decreased muscle mass. So it puts them at increased risk of falls and kind of leads to this whole sequelae of symptoms that they can have. Additionally, any of my patients who have a history of breast, lung, thyroid, kidney, or prostate cancer, those 5 cancers are have the highest propensity to metastasize to bone. And so just being aware of if they have bony metastases, where those are located. And then if you're seeing a patient maybe who's, 5-10 years out of treatment coming to see you in an orthopedic clinic and they have bony pain that's not really fitting a pattern, kind of came out of nowhere, that should really raise a red flag to you that they should be going to get imaging, because any bony related pain in a patient with a past cancer diagnosis, especially those big 5, automatically warrants an X-ray for evaluation. Additionally, I think when we consider patients who have had radiation therapy, thinking about how far out from radiation are they and where was the radiation. And so one thing that we focused on a lot when Leanna and I were working at UIC is we would see patients during active radiation therapy to maintain their range of motion, especially for patients with breast cancer who need to be able to put their hands behind their head to radiate the axilla. And we can still perform manual therapy techniques around the radiated area, but we're really cautious around areas of active desquamation or having significant radiation dermatitis because that skin's really susceptible to shearing. And so we can still work on all those areas and still kind of implement similar techniques. And then, I think Caitlin kind of mentioned before about how we can use techniques still around other areas that maybe don't have a bony metastasis, or even working near or around a bony metastasis and just being aware of, is the lesion a lytic lesion or a blastic lesion? So for example, patients with multiple myeloma have highly lytic lesions. They actually have the highest risk of fracture of all cancer diagnoses. And so I feel like the only real big no is probably no high velocity thrust manipulations for those patients. And for most patients with bony metastases, I think there's a lot of other interventions we can utilize. But I use joint mobilizations a lot around areas with bony mets, and I have really good results, such as for my patients with head and neck cancer who have significant trismus and neck mobility deficits, or my patients with lung cancer get a lot of thoracic and rib mobility deficits. And I can do it safely just so long as I'm using my clinical reasoning and slowly grading my treatment.
And that is so good to hear from someone like you with your experience, Morgan, because I have to just assume that most clinicians, and I know we did a poll at the beginning of our AAOMPT presentation, but most clinicians, I'm sure, would not feel comfortable using a graded mobilization. I'm sure even like proximal to maybe like metastatic site. So yeah, obviously I absolutely agree in my own practice. I definitely avoid high velocity grade 5 thrust techniques. But I think that we need to remember the clinical utility of like even just like a gentle physiologic mobilization or accessory mobilization as appropriate can really make great differences in either functional mobility or pain modulation in these patients. And those are safe techniques that largely aren't causing as much joint shearing or force than functional mobility on its own. We know some of those studies are true with our studies that look at like an MRI of a prone press up versus an L4, L5, central PA, right? So I think as manual therapy, as we look at it in terms of its pain modulating properties, we're doing these patients a disservice if we don't correctly and confidently utilize these techniques to give them mobility or pain modulation as needed.
And I think that's such a great point, Caitlin, about those MRI studies, because orthopedic oncologists, really use imaging and different scales. Like in our presentation, we talk about Morell's score. There's also the SINS, which is spinal instability scale, and it helps surgeons make a decision about if patients need surgical stabilization for metastases or impending fractures. And a lot of times these patients don't need surgery and might just need radiation, or it's just kind of a watch and wait approach. And so you consider these patients who might not need any type of immediate intervention, who are given no restrictions and told to keep going about and living their life. And so if you think about these patients who are weight bearing every day through a bone that has a met, right? They're twisting, they're coughing, they're laughing, exerting pretty significant forces in some of these daily activities. Our lower grade physiologic movements are not going to be what pushes that bone over the edge. And so I also think that gives me some comfort, because I've talked a lot with our orthopedic oncologists, and it's like their feeling is always, do whatever is going to help the patient as long as it's safe. And we're not going to send the patient out to just go walk around with no restrictions if that's unsafe.
Right. I mean, the patient that I'm thinking about right now, she was doing Zumba 3 times a week and water aerobics. And I was thinking, well, I can't sit here and tell myself doing a gentle hip extension physiologic mobilization for her is any more or less aggressive than doing a step up with the opposite knee kind of driving up in her step aerobics class or in her Zumba class, right? So
absolutely.
Because it's just simply not true.
I think that was going to be the point that I was going to make as well. And then it's the thing that I come back to a lot is the force of my hands with a well-reasoned passive accessory or passive physiologic mobilization. Is that force actually sufficient to cause a problem in someone that, like you both said, is weight bearing, is doing the stairs, is chasing after their children, whatever it might be. And again, I think that comes down to, we have to utilize good reasoning, and we have to do our due diligence to practice at the highest of our scope.
And even from just an emotional perspective, I can't imagine that any of us would want to propagate as clinicians a sense of fragility with this clientele, right? Oh, I can't touch you. I'm not sure what my hands are going to do. Can you imagine what that would do to their psyche in terms of wanting to continue with exercise? So I think we have to be so careful of fear mongering and propagating myths of fragility when we simply don't have the research to back that up, and their day-to-day activity is a lot more challenging. So we owe these patients, we owe these patients to make them feel as empowered as possible with movement and rehab, that this is going to be the right place for them to be.
I really love that thinking, because for so many of my patients, I just hear over and over again how they feel so out of control in the situation that they're in, that, one day their life was just a normal life, and then everything completely does a 180. And so to have patients be able to participate in their normal function and empower them to still maintain an identity as a person and not a patient, I think for us, we have a really unique position to help patients realize all the things that they still can do, rather than highlighting the things that they can't do.
Right.
And, a lot of my patients, will joke and say, I need a punch in, punch out card of this hospital because I'm in so many appointments every day. And they're just bombarded with so much information, and it's not always good information, right? And it's changes to treatment plans, and it's very much what's directed towards the patient is what's medically necessary and what's provided by guidelines and things like that. And of course, patients have a say in their care, but when it comes to the medical decision making, sometimes I feel like they might not have as much input, because they're going to go with what research says and just kind of move forward with that. But in rehab, they get to really weigh in and provide their goals and perspective. And so it is kind of an enlightening moment for them, and a lighter moment amongst all of their other appointments, to feel like they have some sense of control and they can see progress and things of that nature.
I do also want to point out that when we worked on this presentation, we did find research that shows the benefit of manual therapy for patients with and survivors of cancer. So it's not like there's absolutely no research out there. There's just not a lot of it. But just to name a few that I think were really impactful, there was a systematic review and meta-analysis by Yao in 2021 that showed the effective manual therapy on cancer pain and psychological well-being compared to standard care or active therapy. So they found that manual therapy was favored compared to those other treatments. So it was more effective for pain and for psychological well-being. They also found that it could be effective for things like nausea, global well-being, and physical function. So, there is some literature out there that we can point to, and I think it's important that we consider those things.
Agreed.
So another thing I would like to hear from both of you is just sort of, what do you wish that most orthopedic or most manual physical therapists knew about the oncology population?
I think biggest thing is it's not as scary, I guess would be a word, or intimidating as it might seem. I think so much of it just comes from all the things we've been told in school, and at no fault of any of our own, right? It's just maybe research hasn't caught up yet, and we just don't really have a great, well-rounded view of oncology rehab. And it is obviously evolving every day, and the amount of specialists keeps growing, and the Academy of Oncology keeps growing. And as I said in the beginning, I think that orthopedic therapists are in a really unique position to help these patients. And if you take away the cancer diagnosis and just remember to look at their deficits and their goals, that can be a really good place to start. And then kind of backfill with some of the oncology knowledge to then help guide your decision making.
Yeah, and I think I can just piggyback off of that a little bit. I mean, you don't know what you don't know until it's in front of you, and you realize, okay, I've got some work to do. So I think as we all are as we look at statistics, we're going to be seeing more of these about more of these patients and seeing a lot more patients who are also in their survivorship chapters, right? So I think that we all need to do a little bit of due diligence, whether it's taking a CEU course or finding some mentorship or doing some reading, and think about, I need to be prepared for these patients start sitting in front of me, and how should I differently structure my subjective? What questions do I need to ask about pharmacologic management, so that you have resources kind of at your fingertips? Because we all need to recognize that we're going to be seeing this more, and we should be maybe doing a little bit of some proactive, maybe like decision making and self-education to prepare ourselves for that, and know a lot of our skill sets that we have already in our toolbox are readily available for these patients. They just may have to look a little different.
Well said, both of you. I would completely agree with both points. And I think that what I would add to it is I wish that ortho clinicians or manual therapy, physical therapists understood the impact that they can have on these patients, even just within a single session. When you are dealing with a cancer diagnosis, to be treated as a human and to be treated as someone that may really benefit from that therapeutic touch is really impactful. So before you automatically rule it out in your head, I would encourage people to pause for a minute, do what Katlin said, do some reading, look some things up, reach out for mentorship. Don't let yourself be intimidated, as Morgan said, and maybe think about what you could do to impact this patient's life. So last question. What was your main takeaway from working on this session? Like, what's the main thing that has stuck with you, or one thing that you hope our attendees or our listeners today will take away from this?
I would comment on Katlin's case briefly, just to give an overall picture. Katlin treated a patient with bony metastases. I believe it was metastatic breast cancer, correct, Katlin?
Yep.
I think so much of what we've commented on in this session is about treating the patient in front of you and just, seeing them as another human being and treating the deficits and looking at their goals. And I think, Katlin, you treated this patient through a time when she really wasn't able to participate in some of her normal activities, and she had a large goal to go on a huge trip with her family. And I think that the therapies that you provided, providing manual therapy for pain modulation, helped her so much, and she was able to go on a really impactful and important trip to Europe with her family. And I know you mentioned that was, one of the last big things she was able to do before she passed. And so when you just think of the impact on that for that family, for that patient, and how much that probably means to her and to them, I just think that there's such a large role for us to play to really make big impacts in people's life among all stages of life. And so just when I hear stories like that, and you get to be involved in really life-changing things, honestly, it's very humbling, and I think just helps further drive home how impactful our services can be.
Yeah, absolutely. I mean, that was a patient that I was alluding to, I guess, to kind of go full circle with the comments from the beginning of the podcast about the patient that definitely was like one of my most impactful patients that I've seen in my years of practice so far. And I had to step back and realize I'm not going to absolve this woman of her pain, but the provision of a window of a pain-reduced opportunity, I think, is really important to look at that. That's just as important as maybe like resolving pain for these types of patients, right? If we can provide, hey, what's a short-term, what's a long-term goal, and how can I help you get there? Before you know it, you realize we actually can have incredible impact with this population. And I think there's important to do a little bit of like a reality check, but also that there's tons of tools that we have to get there. And she was able to go to Italy and clock thousands of steps with her family. And it wasn't perfect, but there's no way she was gonna be able to do that prior. And I think that was because I was able to check myself and realize that her pain was likely second induced to a metastatic lesion at her ischial tuberosity. I'm not sure how much detail of the case we need to go into, but I think where I challenged myself with the help of a mentor was, we're probably not seeing just a lytic lesion or just a metastatic lesion causing pain. We're also seeing some history of an L5S1, like discogenic pain presentation, which was a couple of years prior. And we're also seeing some local nociceptive kind of properties happen in her proximal hamstring, which was absolutely weak and inhibited. And before we know it, we were able to do some like gentle hip manual therapy and some really great strengthening for her glute and her hip. And she was feeling significantly better. And I do not think I would have ever have gotten there if I wasn't challenged by a mentor who made me do some deep diving and really think about the clinical decision-making algorithm that we use to make decisions with these patients. And that's, I guess, the biggest. So all that being said, I think a takeaway message is also goal setting doesn't have to be 0 to 10 pain. It can be windows of extraordinarily emotionally weighted opportunities for these patients.
Really well said, both of you. Thank you. Well, I think that is a great point for us to wrap up today. And I would like to thank everyone for listening. We'll have some resources for you in the show notes. And please feel free to reach out to any of us if you have any questions or would like to chat about this population. I think all three of us are happy to bounce ideas and, just try to empower other therapists to feel comfortable working with these patients. But thank you both so much for joining me today.
Thank you, Leanna, for the opportunity to chat about it.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.